All right. Well, good evening, everyone. My name is Dr. Alice Lee. I'm the Director of Secondary Education for the Palos Verdes Unified School District. Today, we have Dr. Alice Kuo, who is a professor and Chief of Medicine of Pediatrics and Preventative Medicine at UCLA. She practices clinically in the UCLA Health Redondo Beach office, where she sees patients with neurodevelopment disabilities and many adolescents with mental health issues. Dr. Kuo is also the president of the Manhattan Beach Education Foundation. She's a parent. She has two boys, 14 years old, who is a freshman at Miracosta, and an 11-year-old who is a sixth grader at Manhattan Beach Middle School. Thank you so much for joining us, Dr. Kuo. Parents, we will be asking, there will be some time for Q&A at the end, so please use the Q&A box, and we will get to you at the end of the presentation. Dr. Kuo, take it away.
Great. Thank you so much. I just wanted to, thank you all for having me back. Some of you may have seen me before when I gave a seminar to the same group, I think back in May. And I think my talk was a little too long and we didn't have as many questions or as much time for questions. And so today I purposely designed it to be a quick review. And then I decided to go over some cases. Just cases that I've seen in my practice at Redondo Beach, and that might be sort of illustrative of how we would approach adolescent mental health issues. I have a quick talk, almost like a commercial for Alcove, which is opening at Beach City, or which has opened at Beach City's Health District. And then after that, Q&A, and I hope that it's going to be a good, maybe half hour actually available for you all to ask me questions. The review from last May, just a few slides, just remembering that adolescence is that period of time between the dependency of childhood and the independence of adulthood. So that it is naturally meant to be sometimes a little bit of a contentious period where parents are trying to maintain some control over their adolescent child's decision-making while the child matures and becomes more trustworthy and able to understand the long-term consequences of their decisions, and that adolescent children may not be aware of their own maturity level and ability to make good decisions. And so there's this struggle that I mentioned, this natural, very common struggle. And I just want to affirm all of you and me as a parent of an adolescent now that this is normal. I think for myself with a 14-year-old who's about to turn 15 next month, starting to think about letting him drive and getting his permit, it's I think where we really should assess, is this a kid who's ready, mature enough? Or is he a young 14 and maybe we might wait a couple of years? So I think it's really important to recognize that every child is on their own trajectory and not all 14-year-olds are equivalent. And so as a parent, if you have concerns or questions, you can talk with a trusted pediatrician or provider who can help you evaluate that in your child. So we're going to jump right into mental illness. And the reality is we do have a bit of a mental health crisis in the United States, with upwards of 20-25% of adults having some mental health issue. And as I teach my trainees up at UCLA, these adults don't arrive at age 18 and just all of a sudden start having problems, so 75% of mental disorders have their onset before age 25. More than 50% of young people will experience a period of mental ill health before that age, and it is the leading cause of disability and poor life outcomes for young people, contributing to 45% of the overall burden of poor health outcomes in those aged 10 to 24 years. The onset of mental illness peaks in adolescence and early adulthood, with 50% of all mental disorders developing before age 15 and 75% developing by the age of 25. I was just sharing before we opened the webinar that, for me in my primary care practice, fall of 21, I saw this, a lot of high school kids coming in with suicidality challenges, depression, anxiety, pretty obviously tied to the social isolation of the pandemic. But this past fall of 22, we are seeing a lot of K through 6. So as young as 6 or 7 and with a fair number of 11-year-olds, and everything in between, of just extreme disruptive behavior in school, kind of, no regard for consequences, lots of suspensions, lots of hospitalizations, unfortunately. And so I fear that this is still perhaps ongoing impact of the pandemic and the social isolation or the family discord that developed during that time, and that we're not going to see the decline of these rates for quite a while until we shore up our mental health system. So just some brief statistics, one slide only. The most common adolescent mental health diagnoses are, number one, anxiety. I see that in spades. They're obviously coming off of the pandemic, and even before, is a lot to be anxious about. There's a lot going on in the world right now. War in Ukraine, civil unrest in parts of the United States and things like that. So it's a kind of a weighty world to live in right now, and adolescents, as they become more aware of the news, discussions in social studies, and humanities classes, I think that they're exposed to a lot more. And if families aren't used to helping their children process this information, kids are sort of having to figure out how they fit into this world. So anxiety is number one. Depression is also very common. I consider anxiety and depression sort of two faces of the same coin. They're both mood disorders. And some people present with their mood disorder with more sort of activating energy, nervousness, that kind of thing. And some people present with depression, which is more sedating, kind of, lethargy, low energy, unable to get themselves up, and things like that. I want to, recognize that substance use is an issue, and it is very pervasive in the South Bay, in our communities. Ironically, where there is more affluence. So alcohol is by far the most common. 10% of 8th graders and 33% of 12th graders report drinking in the last month. Also, keeping in mind what the legal age of purchasing alcohol is, at least. And 11% of all overdose deaths are in teens. I just received a notice from Beach City's Health District that next Thursday at Redondo Union Auditorium, they will be hosting a town hall on the fentanyl epidemic. I did record a podcast for Beach Cities, as well as, for MBEF. So you can find those podcasts on the website somewhere, about the fentanyl crisis. We fear and, are concerned that these overdose deaths in teenagers will continue to rise until we are really able to kind of spread the word and the availability of Narcan. And I just put a plug in for eating disorders, definitely did go up during the pandemic. The data are still coming in, but this has been confirmed that even at UCLA, we quadrupled our admissions for eating disorders during the pandemic, during the earlier part of the pandemic. So when we talk about depression and anxiety, those are the manifestations or the mental health, issues, but we have to think about what may lead to that. Sometimes there's a family history or a strong predilection from a genetic basis. And so kids who have sort of no reason to be anxious or depressed might present that way. And those are really rare, to be honest. In most cases, I will say that family discord is a very common reason that children have anxiety or depression. I wanted to put a word in for neurodivergence, as we recognize that brains are wired differently, and that 10% of kids will have ADHD, 8% have a learning disability, and 2% autism. That in a school setting, where in general, even though I know that curricula are moving towards individualized curriculum, it is still an expectation, almost a generic one size fits all in most public schools, where, classroom sizes are 25 plus, and one teacher has to manage all those behaviors and all those learning styles. And sometimes kids with these conditions may feel inadequate, substandard, they notice that their colleagues or their peers are getting the right answer without as much effort as they're having to put forth, and that will lead to self-esteem issues that can then, manifest as a mood disorder. I had a patient who was a sixth grader who told me when he found out that he was autistic, that it was like being an Android phone in an iPhone world, which I love and use that kind of phrase because it came from the perspective of an autistic child, but also seemed to illustrate somewhat compatible, but still some pretty significant differences. And so I often say for autistic children or any child with a neurodivergence that they are entitled to, have anxiety, because I can only imagine what it would be like to be a minority brain in a majority, kind of non-autistic situation, and having to navigate the world when most people don't seem to understand you. And so that, I think, has a wearing effect, a stress effect that just doesn't seem to go away. And so in my experience, many of these children and adults will have clinically significant anxiety that would require some sort of treatment. I wanted to put a plug for this as well. This is obviously in the news. There are states that are banning gender affirming care and care to LGBTQ individuals. Many entities are very concerned about the lack of services for these children. And the bottom line from a mental health perspective is that the research clearly demonstrates, with no question, that gender affirming care greatly improves the mental health and overall well-being of gender diverse, transgender, and non-binary children and adolescents. When we talk about gender affirming care, we're talking about, acknowledging how a person wants to be identified, using the appropriate pronouns, using the name that they want to be called. And so we at UCLA Health have moved 100% into that. As soon as an individual of any age identifies as a different gender, we change it in the medical record, we change the name, because it has been shown that, if you do not affirm a person's identity, the mental health consequences can be quite significant. And not surprisingly, LGBTQ students are more likely to face bullying and harassment, leading to poor grades, higher dropout rates, and homelessness. And safe and affirming schools and health systems, clinics, hospitals are a core element of student success. This has come up in my practice. I care for about maybe 10 to 12 transgender children and adults. We at UCLA Health have probably the largest gender health program, caring for over 4,000 transgender individuals ranging from age 4 to over 80. I myself, the youngest transgender patient that I've had, I think was about 5 or 6. And I wouldn't say transgender, I would say gender diverse. I had one child who was sort of unsure. It was clearly not binary, but we had to work with the school because the child presented before kindergarten a certain way, presented primarily female before kindergarten, started kindergarten wanting to present more as male, and then halfway through kindergarten realized that wasn't how he really felt, and was thinking that he wanted to go back to being female. So that is, I think, to say, not surprising, and also very much more common now to have this fluidity as children are exploring their gender and their identity. And I am not an expert, but I will do my best to answer any questions regarding this area. And so last May, I ended my talk with what parents can do is to listen and talk to your teen without judgment. Bring up concern to your pediatrician or primary care provider. I do think that a lot of times when these types of issues come up, the pediatrician that's taking care of your child since he or she was a baby may not be as comfortable, or may seem like that particular pediatrician sort of focuses on young children. There are adolescent specialists out there And then for myself, I am a board certified internist pediatrician, which means that I am board certified to see both children and adults. We have about 45 of them through our system in UCLA Health. So to find a physician who can both be a pediatrician and an internist or an adolescent specialist might be, something to look into if you're looking for a primary care provider with more expertise or with more experience taking care of adolescents. Be open to treatment modalities. I think today I wanted to cover that a little more in depth. There is talk therapy, which does work. It is time intensive. Many of our South Bay teens, I believe, are very, very scheduled. It is hard to find even an hour a week to do talk therapy, after school between all the activities and sports and everything. In some cases, family therapy is really what's needed. If there has been, habits of communication that have developed over time that aren't necessarily the most productive for individual members of the family or the entire family as a whole, that is time intensive for everyone. But I think, the families that I refer or recommend for family therapy, it has gotten to that point where they have to consider dropping certain activities or making the time for this because it is so important for the family unit. And then finally, there are medications. And I know that there is lots of stigma. I've had some parents be open to medications and they do work. I think there's a lot of stigma around psychiatric medications, particularly for children or even adolescents. There's a lot of preconceived notions. There's a lot of notions of, oh, well, they can just shake it off and just snap out of it. And we can talk about that a little bit in the cases that I present. The overall goal, I think, from the medical perspective, is to help your teen become a successful, thriving adult. I will tell parents that in the office that that's my goal. And I will tell the patient or the teenager that that's what I want for them, and that, we can enter into a partnership to see how we can help that happen. Okay, so I'll jump into the cases, and then after that, we'll talk about, cases you want to discuss. So these are cases that are, kind of generic versions of patients that I've seen in Redondo. This is a situation, Jake, and these are all pseudonyms, but Jake is a 13-year-old boy whose parents are divorcing, and divorce is, it's a fairly frequent and common situation. It's very tough on kids, obviously. So Jake, as a result, feels really sad and distracted. He's worried about what his living situation is going to be and whether he'll have to move. His grades have started to slip from straight A's to now B's and C's. And the counselor reached out to the parents because his teachers noticed that there were changes in his behavior and were worried and just wanted to check in. They brought Jake to see me because some of the behaviors were significant enough that the counselor encouraged them to see the pediatrician. So a couple of notes here. The situation is likely causing the mental health effects on this child. The Michael Gitlin, who is the director of our mood disorders program at UCLA, has said, when we've asked him, like, how do we treat this situation? How do we medicate the child? He basically said, this is a really tough one because LA divorces are notoriously contentious, like a level beyond other places, perhaps. And when the challenges, the custodial issues come up and parents may not, they're not necessarily, hiding their disdain for each other, it makes it very hard for the child who is literally caught in the middle, perhaps trying not to take sides, but then, this is his reality. And I've had cases where if the parent didn't disclose to me that there was all of this going on and the child didn't mention anything, depending on the age, could present as ADHD because he's just so distracted. And so any family issue, if you are going in to see a provider, I would disclose because it helps us to understand what the child is going through. And I had a situation of a younger boy, 8-year-old boy, 3rd grade. So I thought, oh, this is the beginning of ADHD, brought in to see me because the teachers were like, he's not paying attention, he's really distracted. And then we come to find, and again, unfortunately, like, dad was having an affair, mom found out, she was really upset. He was threatening to take the kids. Oh, she was threatening to take the kids and move out. So this situation for this 8-year-old boy was like all he could think about every time. And so you can understand how hard it would be to sit and learn math when that's what's going on at home. And so in this case, my first recommendation would be talk therapy. Sometimes public schools can provide, some counseling services, especially when it's this type of a situation that is felt to be acute. Obviously, if you could find a talk therapist on the outside, I understand in the South Bay that can be difficult. It's also difficult to find someone that your insurance provider will cover. Sometimes you have to pay out of pocket. And then therapy is one of those things where I say it's almost like dating. Like, you have to find the right fit, somebody that your child can relate to, and they hit it off and they have a good conversation, and the child doesn't mind going or even enjoys going to see the therapist. If they don't hit it off, if it just wasn't a good match, I often tell parents that doesn't mean that therapy doesn't work. It means that the therapist might not have been a good fit, and so to try to find a different one. Maybe, if it was a female and the child didn't feel comfortable opening up, you could try a male, maybe someone who's older, younger, someone who likes to play chess. I mean, in order for a child to feel comfortable and open up, there has to be some sort of bond, some sort of common ground to start from before a child will start opening up about their emotions and what might be going on inside their head. And does this type of a child, situation need medication? Sometimes. And just because, during an acute period, sorry, I'll go back, we may, offer Jake medication, even if he does talk therapy, if he continues to have significant symptoms, it doesn't mean he's on it forever, right? So I have a patient right now who recently this month disclosed that they were going through a divorce, or actually, I think it's just like a reemergence of a custody battle. But I asked, and so of course, lots of behavioral issues and schools noticing, and he's getting into fights with his friend, that kind of thing on the playground. And I asked the parents, like, so what is the what's the timeline for this? When is this custodial situation going to be settled? And I think the mom said, we're hoping by like November. And I was like, it's like January. So I understand, court things don't go fast. And so I basically told the parents, I said, so there's going to be a different custodial arrangement after November. And they said, most likely. And I said, well, then this child is looking at maybe 2 years before things stabilize, right? Because between now and November, there's this huge unknown that's super distracting. And then after that, he has to get used to a new custodial arrangement, which is a period of adjustment, which is kind of a big deal. So, offering medication for the stabilizing period, once things stabilize and things get better, absolutely stop the medication. But as long as all this is going on and it's affecting and causing symptoms, then we would be, offering medication. Okay. Case number 2, Brittany, a patient that I had in Redondo. So she was a 14-year-old freshman, just started high school, and over the summer broke up with her first boyfriend. So I think they got together in 8th grade, and then by August, it was kind of over. And then at the same time, and I didn't quite catch the details, but basically her best friend of many years sort of like betrayed her over this breakup. She was crying so hard that I couldn't really get all the details, but that was the gist of it. And both parents brought her in to see me because she had been crying and moping almost nonstop for 2 months straight. And mom was concerned, and probably I'm thinking that the girl probably confided a little more in mom. Dad was clearly irritated and thought she was being a drama queen, said it in the room. She's just being a drama queen. Like, she just needs to stop crying. Like, this was just a boy. This was just like, it wasn't even that serious of a relationship. He was saying things like that. And so it was pretty significant how hard she was crying, given that the breakup was more than 2 months ago. And, young love, I understand. And definitely when you're at that age, life is bigger, right? Emotions are brighter. Like everything is more intense, I think, when you're an adolescent. And so, in these types of situations where she was actually, sobbing in the office, I just asked, like, have you ever thought of hurting yourself or ending your life? And she said, almost on a daily basis. And I, like, mom and dad jaw dropped open. So I am pretty sure they didn't realize that she was feeling that way. And mom was completely freaked out and open to the conversation about medication and things like that. Dad stopped talking, but he was listening. At the end of a visit like this, I offer the medication, and in this case, she got on it. And then, obviously talk therapy. Mom is like, I'm going to tomorrow start looking for a therapist for her. And we did a safety contract because I said, well, if you're thinking about this, my safety contract and most people's safety contracts includes, if you're feeling like hurting yourself, you have to tell an adult, and most kids will agree to that. Most kids don't actually want to, and the end their life. And the concern at this age is sort of the impulsivity, right? We talked about the adolescent brain not being fully mature. Again, we talked about emotions being super intense, and it's just a combination of that can lead to an impulsive behavior that could potentially be irreversible. So I take these thoughts very seriously, because unfortunately suicide kind of only has one direction. And so better to be safe and to put things into place to prevent anything. And with these prevention strategies, actually a lot of adolescent suicide can be thwarted or prevented. And so the safety contract, as I mentioned, is the child has to tell an adult if they're thinking seriously about hurting themselves. The parents are instructed to lock up all the knives and the medications, to take locks off of doors to bathrooms that have bathtubs, and to, consider any other method in the home that could be used in an impulsive act. And so, that conversation often is very jarring for parents. But again, the goal is to prevent any kind of final action that is irreversible. With talk therapy in place, with the medication that tries to even out the chemical imbalance, oftentimes, we can start to address some of the issues and decrease the intensity of the emotion that the child is feeling. Okay, so Connor's been one of my patients for a long time. Again, still a pseudonym. He was a junior last year. I think he's been my patient since he was in 6th grade or 5th grade. Generally a straight A student. Plays club soccer for Beach Football Club, Flight 1, which is pretty good. He was always very proud of that, telling me about recent games that he'd had. He has struggled with ADHD and anxiety since 6th grade. And there's been some kind of disagreement among parents. I think dad is open to the medication and wanting him to do well in school. Mom has a very fixed belief that Adderall is going to kill him. Just from what she has read, it's like the most evil drug. And she wants him to learn to deal with his anxiety naturally. He wants to go to college. He had really strong ambition to go to a UC or to go to a really good college with a really good soccer program. And then junior year happened and his academics really kind of took a dive. He was taking college prep classes. He was pushing himself. I didn't get the sense that the parents were telling him to enroll in all of these advanced classes, but he had this notion that this is what he needed to do. And I routinely get what I call the SOS emails, that, emailing me or messaging me through the system, like, Dr. Kuo, we need your help. He's failing this class, or, he refuses to finish his homework, or he's mouthing off to his mother, or he's picking and fighting with his younger brother. Whatever it is, I would get these emails. And then recently they're sort of like, and he's never going to get into college, and what's going to happen in his future. And I'm like, okay, he's like 16. Let one thing at a time. And I wanted to highlight his issue, which is he did get COVID a year ago, and he was out of school for about 3 weeks. I think the brain fog just sort of lasted a long time. He already had the ADHD. He wasn't regularly on medication. I actually can't keep track of when dad succeeds in getting medication in him, and then when he gets better, mom is like, he doesn't need it, and then takes it off. But basically the COVID really took a lot out of him. And then literally the whole rest of the school year last year was me and the family and the school trying to get him through and just to pass his classes. And so I wrote for a 504 accommodation where he didn't have to finish every single assignment, that, the teachers had to accommodate his ADHD. And it was kind of a little bit cruel to say, keep up with the current material and make up like a month's worth of material that you missed when you were sick. So the school did work with him to reduce the amount of makeup that needed to happen. I think we did temporarily stop the soccer so that he could have rest and be able to focus on his schoolwork. I think we did have him on medication at some point in the spring so he could actually do the work. And he was able to pass all of his classes by June. So far, so good senior year. I'm expecting to hear from them soon. And then finally, I just wanted to highlight this case, Emily. It's an unusual case. I mentioned I take care of about 10 or 12 transgender or gender diverse children. She came to see me when she was about 12. Interestingly, she told her mother that she wanted to see a therapist. She was just saying over and over that she wanted to see a therapist. And the mother didn't know what to make of it because she never disclosed anything. She never said why. She just felt like she needed to see a therapist. So actually the mother brought her to see me, a pediatrician. And it took, I want to say 40 minutes to finally get down to it. So I did all the screening, like, how are things at home? How are things at school? What are your activities? How are things with your friends? Everything. And then finally, even though she was only 12, I kind of asked about like, so, sometimes, I asked, what puberty is. And I said, sometimes around this period, you'd start to develop, like think you might like someone. And that's when she this was in the privacy, 12, 13, 14. Oftentimes pediatricians will ask, for parents to step outside, give the child some privacy, sort of, give them practice in advocating for themselves, telling us their medical issues. And so this was privately without her mother in the room. She said she might be a lesbian. And I said, okay, do you know what that means? And she said, well, I think I like girls. I said, well, that's fine. I said, that a lot of times kids this age are figuring it out. So she might be, she might not be. But I could see that it was starting to cause a little bit of angst in her. And I said, well, if you did like girls, what do you think? And she said, I don't know that would be so good. And I said, well, nowadays, like we want to just be open and accepting of who people like. But at 12, that was the extent of the conversation. We did not go beyond that. Saw her, for other things. And then at 13, during one of our sessions, she disclosed that she actually had a crush on a friend who was a girl. So I said, okay, well, last year you thought you might like girls and now you have a crush on a friend. Again, do you have any questions about that? And again, she didn't really have questions, but I almost got the sense that like I was the outlet where she could tell someone. And then, basically she said that her parents were not supportive and she couldn't talk to anybody about it. And so we went from maybe she might be a lesbian to the following year, she came and said, I think I want to present as a boy. And I said, oh, that, again, this is your journey. What do you know about it? Can you talk to your parents? I said, when it's just like who you like and who you have a crush on, and, if you're not actually dating, that's not so public, I suppose, not so obvious. But I said, if you want to present as a boy, I said, I think you really should tell your parents because hiding it can be stressful. And she just reiterated, absolutely not. Her parents were very traditional. It was, there was no ability for her to think that there would be a role for telling her parents. She did have an older half sister who she said she could confide. So she was like 14, her older half sister was like 26 or something. And she did confide in her. And I said, well, can your sister help you? And she said, well, no, not really, because the parents are, very traditional. And so I kept encouraging her. I kept saying, we're here to help. There are programs. We can give your parents some information. And then basically, the next time it was, escalated. And at this point, the parents did know, because basically in PE, she told her teacher that she wanted to be called Eddie and use he, his pronouns. And so that was the first the parents ever heard. And then they brought her in, or him in, at that point. And so then began the process of like, well, let me introduce you to our gender health program. They can educate you about some of the opportunities or options and all the conversations. And so, I think that this particular child had a lot of stress through his coming out journey, and it can, at this age, take multiple years. It's not like the light switch goes on and all of a sudden. A lot of times what I have seen is that it is a journey, sort of realizing that they may like someone of the same gender, or they may find themselves non-binary or gender diverse. And this is a new phenomenon. I think there are estimates when you look at the research that roughly 4% of the population may be gay or lesbian, and then 1% of that might be gender diverse. I think the precise estimates are kind of hard to get, but already in ALCO, we have seen this issue, and just want to emphasize that, an affirming environment where we accept people for what they want to be or what they feel they are, and not impose something that is not compatible with how they're feeling, would be really important from a mental health perspective. Okay, so I mentioned Alcove a couple of times. Alcove opened its doors at Beach City's Health District in Redondo Beach, right upstairs from our UCLA Health office, on November 1. And there have been kids dropping in, and it was patterned after the Headspace model of adolescent wellness centers in Australia, where it's an inviting environment, a space designed by the youth to just drop in and meet with a peer counselor, to meet with a social worker, to have a conversation like, hey, I'm feeling kind of, not sure, things are, I'm having some emotions. And so it's meant to be like an early identification or a prevention place where kids can get connected to services. Because there is such a lack of mental health services in the South Bay. Interestingly, Alcove has reported that kids are coming in with their parents. There's not a stigma. The parents are also wanting help for their child. And so all are coming in, it's open, and everyone is trying to find mental health services for the adolescent. And so UCLA Health is partnering with Alcove because we are just downstairs from them. And, hoping to develop comprehensive adolescent, both physical and mental health services. So it is a little bit of a one-stop shop if you come to our location, because many teenagers are also not connected with their pediatrician anymore. I think realistically, after those preschool vaccines at age 4, some kids go every year for a physical. I think at a certain age, when kids get so busy, like we hardly ever see adolescents for a preventive or a well child visit. It's often when there's a sprain or there's, a sore throat or something like that. And so Alcove can help family connect with a primary care provider as well. Okay. Yeah, okay, 20 minutes. We have 20 minutes. I'm happy to stay a little bit longer as well for questions. And I wanted to have Dr. Lee help to moderate.
Sure. So if anyone has any questions, I'm actually going to stop recording. So thank you, everyone, but I'm going to stop recording. So your questions will be private.